evidence-based, non-operative treatment of femoral acetabular impingement syndrome.
So what we're going over today is going to cover FAI syndrome, a little bit of a recap from the previous episode, kicking it off with a definition from the Warwick Agreement on Femoral Acetabular Impingement Syndrome, FAI syndrome, and then we're going to talk all about non-operative treatment. So what is FAI syndrome? FAI syndrome is a motion-related clinical disorder of the hip with a triad of symptoms, clinical signs, and imaging findings. So really needing all three of those things to call it FAI syndrome. It represents a symptomatic premature contact between the proximal femur and the acetabulum. We have two different types there, the CAM lesion, which is an overgrowth on the femoral head, and the pincer lesion, which is a overgrowth of the acetabulum. And the big question everyone wants to know is, can it be treated without surgery? So we're going to be diving into this paper. This was a 2020 paper titled Short-Term Clinical Outcomes of Hip Arthroscopy versus Physical Therapy in Patients with FAI, a systematic review and meta-analysis of randomized controlled trials.
My name is Dan Pope, and this is Kevin Coughlin. We are physical therapists at Champion PT and Performance. We have helped to make thousands of incredible coaches and clinicians through online courses, communities, and mentoring programs. And the goal of today's video is to make you 1% better.
Okay, the purpose of this article was to perform a meta-analysis of randomized controlled trials that compared early patient-reported outcomes of hip arthroscopy versus physical therapy in patients with symptomatic FAI. The authors had a hypothesis that surgical treatment of FAI would lead to better short-term outcomes than physical therapy. Hate to see it. The methods were they used they found three randomized controlled trials met the eligibility criteria, which combined included 650 patients. So a pretty decent size there. All three randomized controlled trials reported international hip outcome. They reported outcomes using the International Hip Outcome Tool 33. In the research, you'll see the IHOT 33. That's that outcome measure. And two of the studies reported on the hip outcome score, so the HOS, ADL, and HOS Sport. So a couple different subsections there. And then I thought this was just nice because the Warwick Agreement and the recent non-arthritic hip pain clinical practice guideline, they recommend using the IHOT and the HOS as part of an outcome tool questionnaire. So it is in line with the best evidence right now of what outcome measures to give patients. So I thought that was pretty good.
Hey there, Broseph McJoseph. I hope you like treats. Evidence-based treats, that is. It's an evidence-based cheat sheet for diagnosing and treating femoral acetabular impingement. Now, not everybody loves searing hip pain right through the front of the hip as much as I do. And if you want to make any money as a physical therapist, you're going to have to help patients with this type of hip pain. Trouble is, got to stay up to date on this condition to know how to treat it properly. And that's where I come in. With this handy-dandy little cheat sheet, we'll catch you up to date on the medical literature on femoral acetabular impingement syndrome in under 10 minutes. We go over a lot of good stuff. Definitions, prevalence, incidence, population, anatomy, risk factors, pathophysiology, mechanism of injury, clinical examination, differential diagnosis, and treatments like physical therapy, injections, and surgery. Best of all, this is a free download. I'll leave a link in the description. Go ahead and download it and get your learn on. And now back to this video.
And then diving into the results. So again, this was 650 patients with FAI, and there was a mean follow-up between 8 and 24 months. So fairly mid to short term, but we got a couple year follow-up there, which is nice. All studies reported that the patient reported outcomes improved from baseline to follow-up for both physical therapy and for surgery. So that's pretty cool. Both groups of people within these studies, whether they did PT or surgery, seemed to get better. However, surgery resulted in significantly better patient-reported outcomes than physical therapy via the IHOT and the HOS ADL, with a significant difference exceeding the MCID for each outcome. So there was a little bit better outcomes in the surgical group here. This conclusion is consistent with the two higher quality randomized controlled trials that were included in this review. There was one study in this review, and it was by Mansell et al., and that showed that there was no significant difference in outcomes between groups, but the authors were kind of harping on the fact that there was a 70% crossover rate in that study from PT to surgery. So what they kind of recommend here in the discussion section is that future research needs to determine which patients will do best in surgery versus physical therapy, as well as which patients are destined to have poor outcomes in PT or surgery. Obviously, those are things we're always trying to figure out. Several papers, as well as this one, recommends 3 to 6 months of physical therapy before trying surgery. I think a caveat to that is something Dan mentioned in our prior episode, is that if these folks have an alpha angle of, was it over 60 or 65?
I think 65 was a consensus. Yeah.
Yeah, they might want surgery before even trying physical therapy. But that might be up to the surgeon in that particular case. But I think still a good case to be made for trying physical therapy first. And if you're not doing well, like in that Mansell study, there's a pretty big crossover to surgery. But we like to think with physical therapy, people have the best outcomes with every pathology. But there does seem to be a case to be made here in this study from 2020 for a little bit better outcomes with surgery. And then obviously keep in mind, this was 24 months in duration follow-up, and it's always good to see longer term studies. So hopefully more of those continue to come out.
Yeah. It's always sad, right? You want to see physical therapy win every single time. This is one of those cases where you can have some success, right? But I think the other part is that you can expect a decent amount of patients to go on and get surgery. And the other part is that maybe surgery is actually the best decision, right? I think that's just a really tough thing to reconcile as a physical therapist. Sometimes we feel like a failure if we don't get patients better and they have to get surgery. But in this situation, it may actually be what's best for the patient. So you got to keep that in mind. You're forcing them to do physical therapy. You might actually be keeping them from doing what's actually more effective for them. So that's important to understand too.
Yeah, and I think it's always nice when we do have some guideline on how long to try physical therapy for. So they concluded this article, they were saying in patients with FAI, the combined results of 3 randomized controlled trials demonstrated superior short-term outcomes for surgery versus PT. However, PT did result in improved outcomes, and it did not appear to compromise the surgical outcomes of patients for whom therapy failed and who progressed to surgery. So that's awesome, right? Try physical therapy first for a period of probably 3 to 6 months. It gives you some guidance there, which I think is great. It's consistent with some other studies. And if symptoms don't resolve, I know you had mentioned a little in a previous episode, we could consider an injection, whether that's diagnostic to make sure we need this surgery, or if it does relieve symptoms a little bit for a period of time, that's a good idea, or consider surgery. Um, but I wanted to dive in a little bit in this paper to what the physical therapy groups did, just to see if it gives us some guidance on treatment or if we think we could do better or something like that. So um, they do talk about this fashion study. This was a 2016 paper in the British Journal of Sports Medicine. It's titled Personalized Hip Therapy: Development of a Non-Op Protocol to Treat FAI in the Fashion Randomized Controlled Trial. And this group aimed to develop a protocol essentially that was adopted by the randomized controlled trials in that study. So the goal of their development, why did they do this? They wanted to develop and undertake initial testing of physiotherapist-led non-op treatment for patients with FAI that could be compared with arthroscopic surgery in large pragmatic randomized controlled trials. So they were making it for this purpose of, let's compare this protocol of physical therapy. Let's all be on the same page about what the protocol is going to be, and let's compare it to surgery. They combine results from a systematic review, 2 rounds of Delphi consensus studies, relevant literature, and the experiences of physiotherapists treating patients with FAI within the internal pilot randomized controlled trial in order to develop this protocol. Um, the protocol provides guidance to clinicians and researchers in an area where evidence is limited. So always good to get people on the same page here. The program was delivered over 12 to 26 weeks in 6 to 10 treatment sessions with a home exercise program for these folks to do at home. There was a detailed personalized assessment. So that just included a typical subjective and objective examination with an emphasis on assessing muscle strength, assessing range of motion, and doing some special testing. It included education and advice. So they educated the patient about FAI and the various treatment options that are associated with it. And this was important to the researchers for some shared decision making. They were thinking um, in the realm of the biopsychosocial model, which I think is great. This also included education about how to modify work activities. So Pennick et al., I think is one of the papers that Dan had mentioned in the previous episode. They found an 82% success rate of non-surgical management when alterations in activity level were accepted by patients versus 41% in those maintaining the same sport level. So basically, if your patient is willing to bargain with you a little bit and they need to modify some things, whether that's lifestyle factors of how they're sitting in a chair for a long period of time, what types of activities they're doing either in the gym or with sports. Those who are willing to make a small alteration to calm symptoms down tend to do better. So that education was a critical component of this program. The third out of fourth component was help with pain relief. So they said it was okay to take anti-inflammatories in this initial rehab phase for up to 2 to 4 weeks, so long as they didn't have any other issues taking anti-inflammatory medications. So that was another important part. The fourth component of the program here is supervised physical therapy. So to go along with all that, in the physical therapy, they advised physical therapists to do manual therapy, which I think is great for something like this. So hip joint mobilizations were allowed, and this included just regular traction or distraction of the joint. They encourage mobilizations with movement, posterior to anterior and anterior to posterior glides as well. A hip injection therapy was okay to kick things off if they wanted to do a corticosteroid injection. They were willing to allow the therapist to use their judgment if they wanted to trial foot orthotics for these patients. They talked about different taping techniques to facilitate hip external rotation and abduction. And then they used a bunch of different exercises, and this was part of the home exercise program. And this just included basic pelvic positioning exercises and supine, sitting in a chair, sitting on a ball, kind of motor control exercises. They did highlight some TA exercises. They did have a table-based hip and core progression, which included things like bent knee fallouts, clams, bridges, prone hip extensions, marching variations, hip abduction, closed chain external rotation, bird dogs. Other standing exercises included lunges, wall sits, RDLs, lateral step downs, and side planks. And various stretches included hip flexor and posterior hip stretching. So, kind of a robust physical therapy program. As I was going through it, I don't think they had a lot of long term progressions like in the gym with weights. A lot of these were body weight type exercises. So, if you think about getting back to sport, maybe we need to incorporate some higher level activity. If we're getting back to sport, maybe we need to include some agility, some plyometrics, some return to running. But I think to get all the authors here on the same page of the various studies, this is the protocol that they kind of came up with. And they did cover these four components, but they let the physical therapists use their judgment about what would work best with the patient in front of them. But some guardrails was nice. So that's the treatment program that was in these studies that were included in the randomized controlled trial.
Mm-hmm. Can I talk now? Am I allowed to speak?
Go ahead, sir. Yeah, you got 1 minute.
I know. All right, I'll keep it under 60 seconds. I just want to say I think the modifications thing is very, very important. I've had a lot of patients where just the regular activities, particularly sitting. Sitting is a tough one because we sit so much, as human beings. If you don't kind of modify those positions, it makes sense you don't get better. And I think the same thing goes for sport, unfortunately. What I'll also say is that I try to make a lot of modifications for a lot of my lifters, both at, let's say, the lumbar spine and the pelvis, right? And also stance. So trying to change the angle with the femur, change the angle with the pelvis, just try to reduce the compression there. So I thought that was good. I'm glad they incorporated that. I think that's very important. And it probably is very different based on the sport or activity that someone wants to get back to. So I think the hard part is that it's hard to control for some of those things. Like if you want a soccer player to go play in like a little bit different pelvic tilt, that's a kind of a tall task. You know what I mean? But for a lifter, just squatting and changing the pelvic positions not that tough, right? We can kind of coach that up and make that happen, make that a more permanent solution. So,
yeah, I thought that was fascinating that those that complied and had the ability to modify certain things just did that much better. I mean, that shows how important that one thing is. And you hear that a lot. I think I've heard even a lot of our coworkers say this, is that, you're in physical therapy maybe 2 hours a week. And then how many hours are you on your own doing things? So that's just important to keep in mind. But
yep.
Now, this paper, the 2023 paper here from Pasculi et al., is a paper I'll talk about in a minute, but they were commenting on the meta-analyses that we just covered. They had a commentary on that paper, so I thought this was interesting to include. And they just said that there were several limitations throughout these studies. Certain physical therapy and exercise protocols that served as controlled interventions in previous randomized controlled trials may not represent the current best practice for conservative management of FAIs. In some randomized controlled trials, patient recruiting criteria were not well defined, and this is super important. And some patients have had labral tears, cartilage damage, and or limited radiographic osteoarthritis before treatment, which may confound the clinical picture and results. So we need to be on the lookout just for better research over the course of time that is controlling for some of these things, because you can imagine a non-operative treatment of someone with radiographic OA and a hip labral tear is probably going to be worse than someone with just a hip labral tear. So separating these out, that's like when they look at return to sport rates in ACL, but they don't control for someone with a meniscus tear or something like that, or a
Multi-ligament
previous
knee injury
AC.
or something.
Totally. Yeah. I mean, there's other things to consider there. So that's interesting. And then furthermore, most of these randomized controlled trials only evaluated short-term outcomes. They were less than 2 years, leaving the mid and long-term benefits of both hip arthroscopic surgery and physical therapy to be investigated. So as always, we need to be on the lookout for kind of better quality studies over the course of time. But I think that previous study by Schwab et al., it's something good that can guide us a little bit, but it's not the be all end all. We need to consider these other things. And I think just for people looking at research, these are important things to consider: is what's the patient look like in the study, and how well is it controlled, and how much does it look like the patient in front of you? Because that, you can't say that physical therapy is not so helpful for non-op rehab if all these people doing non-op rehab are different. They have labral tears, but some have osteoarthritis, perhaps. Some have a little cartilage damage. How significant is the cam or alpha angle or lateral center edge angle? So just a lot of things to consider, to look at the research a little more diligently and with a little more nuance.
Yeah, I can just imagine Pasculi and Schwab like getting into like a bar fight. Like, oh, you said my study had limitations. Just kind of like makes me laugh. It's like they're directly calling out these authors, like, you did a bad job.
Yeah.
So, but really good points. I mean, like, yeah, I can see why they're concerned about those things. And yeah, it's not
Mhm.
really fair, because if you hang your hat, we say it a lot on this one study, it's like, well, it's not really very accurate. So let's see what these newer studies have to say.
No one better come up with limitations of our podcast.
Oh, okay. Got to fight them for sure.
Yeah. All right. So this is a paper. This is from the Pasculi paper. This is from 2023, and it's titled "Non-Operative Management and Outcomes of Femoral Acetabular Impingement Syndrome." So this was 3 years after, so a fairly new paper. And they just talk about a bunch of different things to consider from a non-operative standpoint. And they focus on this area. What can we do in physical therapy? So, they're looking at all these different studies and giving us some guidelines. So multiple sources have demonstrated significant weakness of proximal hip musculature in patients with FAI compared to healthy controls, specifically the hip abductors, the external rotators, the flexors, the extensors, and the adductors. So it's like kind of like everything. It's like I was writing it out, and it was silly to me that they listed every single thing. Um,
Specifically, everything generally.
yeah. So that
Yeah.
was pretty good. In a more recent study using cross-sectional imaging, certain muscles like the glute max, glute min, and rectus femoris were found to be atrophied on MRI, as demonstrated by smaller cross-sectional area in patients with FAI compared to healthy controls. And I think this is, to me, I would guess that they were having symptoms and that they started not doing so much activity, and then they were getting weaker, and having a loss of muscle mass, rather than the other way around, that they happen to be weaker on this side and developed FAI. But that may be true as well. And then they mentioned a systematic review by Freck et al. Identified decreased hip muscle strength and impaired single leg balance as the most common physical impairments in FAI syndrome. So I think we could take all these and just picture on our clinical examination. These are things that we're definitely going to want to evaluate. And then outcomes of physical therapy. So how did people do when they did physical therapy for non-op rehab? They cite one article that was a cohort study in which 76 patients, and this is a younger cohort, 15.3 years old was the average age, with a range from 10.4, that's so young, to 21.4. And they were followed for about 2 years. 65 of these hips were managed with physical therapy. 11 required a steroid injection, and 17 required arthroscopic management. So
That's a panic study, right?
Yes, yep,
Yeah.
yep. So this had 76 patients, and then 18%, 17 of them ended up requiring surgery over this 2-year period. All groups met the minimally clinical important difference in the modified Harris hip score and non-arthritic hip score. And then you did mention this before, right? So hips with CAM and combined CAM and pincer were 4.4 times more likely to need surgery versus the pincer alone. So for whatever reason, it must just, a CAM seems to be more indicative of who may go on to need surgery. And then the same group of authors had another follow-up at 5 years. So they spanned out the study a little bit to look at a little bit longer term outcome, which I thought was great. And only one more patient went on to have surgery after the 2-year follow-up. So I think the number was 17, and then it went up to 18 after the 5 years. So their conclusion was that non-operative management of FAI is effective in a majority of adolescent patients, with significant improvements in patient-reported outcomes persisting at a mean 5-year follow-up. So that's awesome. I mean, kind of what we see at 2 years, we're going to continue to see into the future. And that's what this study kind of showed. It wasn't the biggest N ever, I think, 76 patients, but shows that in this younger group, we can often treat this, or at least we should still try to treat this non-operatively, and then kind of see what happens and know that surgery is an option for, in this case, about 18% of them.
If they stopped doing research after this study, I would have been like, yes, PT is the best.
Yeah, I know.
But
Yeah.
I assume you're going to go to the other stuff next, and we'll see some
Yeah.
differences.
Yep. So this was a cool study. This was from a month and a half ago to date the episode. So this is March 2025. And this is titled Femoral Acetabular Impingement, Critical Analysis Review of Current Non-Operative Treatments. So they just get into a bunch of different non-operative treatments that we'll dive into. And then just, to give us a little bit of new updates, what they kind of said in the paper here is that FAI has been shown to have substantial implications on the native hip biomechanics. Namely, patients with FAI demonstrate restricted hip range of motion, diminished functional strength and proprioceptive capability, and reduced periarticular muscle bulk when compared to healthy controls. So that's similar to what the other research has told us, things that we see that we should be looking at with our patients when they come in for an evaluation, things we want to measure. Patient education and a treatment plan to address these impairments is paramount in non-op hip rehab. Education on what positions to avoid. So I talked about this in a previous episode, but if the fader is maybe not the best at having us tell the patient that they have FAI or they have a hip labral tear, we can use it to show them what position of their hip is very provocative and how we can modify this throughout their day. We can also show them, if we're doing like an active assessment where they're doing deep squats or lunges, or we're doing passive range of motion of hip flexion on the table and it causes pain, we can relate that to daily activities where they're in a lot of hip flexion and try to find alternative strategies to modify these activities so they feel a little bit better. And like we talked about earlier, we know patients who can modify some of these activities do really well non-operatively. we can't find ways to modify, or they're not compliant with that, we know that that increases their chance of needing surgery. They also highlighted the need to design an effective rehab program to address the specific impairments. And this is really, core and hip neuromuscular education programs, strengthening and endurance training. And then we want to go through a robust evaluation and try to figure out, how weak are they in, say, their hip abductors on the involved side versus the uninvolved side, and make sure that's something we're reassessing as we progress rehab, and see if we can help these patients kind of get stronger, regain that muscle bulk, and get back to kind of their prior level.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms, or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door, so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. Yeah, I think that, again, that modifications one is huge. And to be honest, it's funny because I try to get everyone to modify, every one of my patients, for pretty much every single pathology. I just feel like FAI is a huge one, right? And generally speaking, like I go through sitting in a taller seat, space between your knees, trying to slouch a little bit to increase some space there. I think that's super important. It's also funny to me how poor people are at following these recommendations. I get this for FAI as well as gluteal tendinopathy. Like, all right, sit with space between your knees, right? Trying to cross your legs. And like, they'll continue crossing their legs like 1,000 times throughout the evaluation. And like, I just point to it. I'm like, you're still doing it. You're still doing it. You're still doing it. So I think these modifications are very, very important. But the people often have a tough time trying to follow that advice, I guess, you know?
It's like every time I try to like fix my posture, I'm like sitting up tall, and then 1 minute later, I'm like melting into my chair.
So tired.
I know. Yeah, it's just those learned behaviors. So just more about this updated paper. They talked about a paper from Kemp et al., which demonstrated that the employment of a 12-week physical therapy program incorporating hip and core strengthening alongside patient education significantly improved hip pain and functional outcomes in patients with FAI compared with controls. So if we're thinking about what do we do, hip and core strengthening and patient education seem to be pretty helpful in these folks. I'm not going to attempt to say this author's name. I'll probably just butcher it, but they found that implementation of a core strengthening and trunk stabilization program within patients with FAI conferred significant improvements in hip flexion range of motion, hip abduction strength, and the Vail hip and IHOT 33 scores at 4 weeks and 8 weeks post-operatively post-intervention compare with controls. So again, what do we do in physical therapy? We can work on a core and a trunk stabilization program, which I think would be very helpful. Interested to know the difference between core and trunk. Seem kind of similar to me, but that's okay. And then a recent meta-analysis of 5 randomized controlled trials incorporating 124 patients with FAI. The mean age for this one was 35 years and an average follow-up of 9.4 weeks. So very short-term follow-up. Found that hip and core strengthening protocols, active physiotherapy, and supervised physiotherapy conferred statistically significant improvements in patient-reported functional outcomes compared with patients who underwent no core strengthening, passive modalities, and unsupervised care, respectively. So there was a nod here to physical therapists and supervised care doing better than unsupervised. And I do like to see that in the research because I do think our coaching and our exercise selection and being there with patients can be really important. And if we're doing a good job with that, it does seem like we're getting slightly better outcomes than if they're just doing this thing on their own with no real professional guidance. So AI is coming for all of us, but maybe we'll still have a job here with our supervision, which is good.
Just got to be in the room,
That's right.
watching them.
Yeah.
One thing I think that was interesting, and it kind of goes against what, and I think this is dying down a little bit, but for a period of time, when folks had FAI, like the solution in social media was like stretch into internal rotation, right? I don't know why that trend existed, but it was like, you got to improve hip internal rotation range of motion. And it was kind of like, I get it in the sense that if you have an Achilles tendon injury, you strengthen Achilles tendon, right? So you're kind of like promoting the same thing that hurt you. For FAI, it's like you hurt by going into too much flexion and internal rotation, uncontrolled, too many reps, whatever it is. Jamming into more internal rotation maybe makes the area adapt, but none of these studies include stretching or mobility into those positions. So I often get patients where, and maybe this is just big in the weightlifting world, where like I have this kind of painful pinching hip in the front side, and I went on Instagram and I've been doing lots and lots of stretches and internal rotation. One of the first things I do is I get rid of that, right? That's the activity modification because you might be just provoking that area. Yeah, and I tend not to do a lot of stretching. And if I do, it's in positions that don't hurt. And then once pain dies down, obviously we need to get back to those same positions. So I may push it eventually to drive some positive adaptations. But I just think it's important that folks are reading that, they're seeing that these studies are not promoting mobility. They're not telling you to stretch into maybe a Thomas stretch, posterior hip stretch, like in that first study, but largely they're not stretching these folks. So, and range of motion improves without stretching or pushing those end ranges. So just wanted to point that out.
Yeah, just on
Whoa.
that point real quick, because I do think it's important, is that it's like our mentor and boss, Mike Reynolds, says a lot, is like not all tissues adapt the same way. Like with your UCL, it doesn't just adapt to more and more and more stress. It doesn't adapt like a tendon does. Like you had mentioned the Achilles tendon. Yeah, we load that area with the issue because it adapts, tendons adapt to load. But if you have these issues from the time you're young, we had talked about in a previous episode, a lot of people who are getting FAI are getting it at a younger age and they're super active. And then I feel like when you're a little older, you're into weightlifting, you're trying to mobilize into internal rotation, you're just hitting a bony surface and it's not going to adapt the same way. And like you said, that's not a highlight of these studies, these most recent studies, especially from 2025, is it's a lot of neuromuscular reeducation in core and hip strengthening. It's not improving hip internal rotation mobility. That might improve over time as a byproduct, but that's not the emphasis. So I thought that was pretty good.
Totally agree.
And then the author's conclusions here were collectively, these studies suggest that patient education and supervised physical therapy can improve, can provide significant improvements in hip pain and function in the short term and midterm for patients with symptomatic FAI. There is, however, a paucity of high quality investigations exploring midterm and long term outcomes following this intervention. This highlights the need for future studies to be conducted. So, as usual, the more long term would be awesome. And then I wanted to touch on this a little bit because this came out in 2023. This was a updated revision of our clinical practice guidelines, which I think are amazing that we have these. And I always tell our students that if you're going to start somewhere on a certain issue, just see if we have clinical practice guidelines for it and try to become familiar with it, because these authors work super hard to get this out there, and it doesn't include every single thing, but it kind of guides us in the right direction. So this is the non-hip, this is the hip and movement dysfunction associated with non-arthritic hip pain. And yeah, a revision in 2023. So that 5-year revision that we'll talk about a little bit.
Yeah, having been involved a little bit in the APTA and not very much, I second that. This is a very thankless job, and the work that these folks are doing is awesome, and they're not getting a lot of credit for it, right? No one's paying them or anything like that.
Yeah. Yeah. So just I want to highlight a couple of the important things here. Like, what can we do as physical therapists? You have a patient in front of you. What does the research kind of say? This is something we should really be focusing on from a non-operative standpoint. So for examination, what measures should we be using? Talked about this a little bit, but the IHOT is one out there that you'll see that does have good validity, something we could be using. The Copenhagen Hip and Groin Outcome Score, another one you see out there quite a bit. That's abbreviated as the HAGOS, HAGOS. The Hip Outcome Score, the HOS, and this has like an ADL and sports related subsection. Those are also great to use. So I think implementing those outcome measures with patients is a no-brainer. For physical impairments, what should we be doing on our examinations? What should we be looking out for? We're doing some good objective testing with reproducible measures of hip pain, hip mobility, muscle strengthening around the hip and the core, movement coordination, something we should be looking at. Assessing range of motion and probably getting measurements would be important. Assessing for hip internal rotation, external rotation, flexion, all the movements of the hip. They should all be included in our examination. Could pop over to the next slide. And continuing with examination, getting into activity limitation and physical performance, we should include measures of function and postural control in the form of performance tests, such as the single leg squat test, which I think is great for this population. The star excursion balance test is another good one. Looking at hop distance and single leg sit to stand, as well as time measures of function at baseline and stuff that we can just compare to down the road. So, you could pick some of your favorites or your ones here that are most applicable to the patient in front of you. And again, yeah, that says B-level evidence. So I thought that was good. In terms of interventions, again, with B-level evidence here, we should use multimodal interventions consisting of activity modification. That's the first one they say, which is great. Strengthening of hip-specific muscles, so all the muscles around the hip and the trunk, and general lower extremity strengthening. We can also use interventions such as manual therapy with good conscience, I think, postural movement correction, stretching. Like Dan had said, I think there's some of these papers are showing anterior hip stretching is good, posterior capsule stretching is good. So pretty good multimodal intervention there that we can use a wide range of things.
Yeah. A little interesting that, because we're going to go over the rotator cuff clinical practice guideline too, because that just popped out, but they are supporting manual therapies, and at least in this environment, I think there's a lot of like shade throwing on PTs that use manual therapies, which is a little bit unfortunate, but it's at least nice to know that, the smartest people in our industry that are kind of writing the guidelines for this are saying that it's okay to do some of that. So I think that's probably positive. I mean, our manual therapy is going to be the best long-term thing that you should use for your patients. Probably not, but I mean, we both use it on a very regular basis. So I just want to come out and say that I am a manual therapy user, right? And it looks like it is supported, at least based on these studies they're looking at, to be helpful. So I think we can use those. It's good stuff.
Totally. With C-level evidence, we have movement pattern training. So again, I think it's important to emphasize, I don't remember all these off the top of my head, but if you go in and look at clinical practice guidelines, any of them, they give you an explanation of what it means to have A through F and E level evidence. And it doesn't mean it's bad. I think that's always important to remember. I mean, I wouldn't think of C as that's bad evidence. It's just that we need more, and it's a certain type of study that has found this. So just keep that in mind. And I think that generally would mean to me is let's just look out for higher quality studies that may change these recommendations over time. But just keep in mind that C doesn't mean don't do. It just means probably do the A stuff first. Make sure you're definitely doing the A stuff and look through the guidelines because they have good recommendations on this for what each thing means. So in terms of movement pattern training, clinicians may provide movement pattern training to optimize lower extremity movement patterns associated with pain during activities. I would just think of this as like someone's having pain and needs to modify, and you're teaching them how to move in an alternate way so they're no longer having pain. I think if you simplify it like that, it's pretty self-explanatory of something we should do. We should use therapeutic exercise with C-level evidence to address joint mobility, muscle flexibility, and muscle strength deficits identified during the physical exam. And then obviously, always should use patient education and counseling. Again, that's supported right now with C-level evidence to counsel for modifying aggravating factors and managing pain. D-level evidence for bracing. So based on conflicting evidence, a recommendation cannot be made for the use of bracing as a standalone intervention. So if you were thinking of just doing some type of bracing with your patient and nothing else, obviously that's not going to be recommended right now. For manual therapy, it says F here for joint mobilization procedures. They may be used when pain or capsular restrictions are suspected to impair hip mobility. Soft tissue mobilization procedures may be used when muscles and their related fascia are susceptible to impair hip mobility in patients with FAIs. And then for neuromuscular reeducation, clinicians may utilize progressive neuromuscular reeducation procedures to diminish movement coordination impairments identified in patients with non-arthritic hip pain.
Yeah. I do think, like you had said previously, I'm trying to remember what these are too, but I don't know if F is expert opinion or what it is or consensus, but yeah, it doesn't necessarily mean that like it doesn't mean that manual therapy has been shown to be negative. It's got an F. It's just that there's very little evidence to show its efficacy, which I think can be confusing because if you look at this and it says neuromuscular rehab, I shouldn't do this. It's F grade. It just means that we don't have as much research, but what we do have is positive, right?
Right.
If there was a strong recommendation against, let's say, ultrasound, that would be like an A level evidence to not use ultrasound or B level evidence to not use ultrasound, just so that makes sense to folks.
Right. Yeah, and I think interesting too, just to note that it's kind of saying that with B level evidence for interventions is a multimodal intervention approach. So there's good evidence for multimodal approaches, which include all of these things. I think it's saying that manual therapy by itself probably not going to be the thing, but they had that B grade for multimodal where you're kind of doing strengthening, neuromuscular reeducation, activity modification, um, manual therapy, and that whole approach together has high level evidence, that B level, which is at least one randomized controlled trial, I believe. So that's good.
I want to say that was probably that 2016 article from BGSM you mentioned at the beginning, because they
Yeah.
utilize a lot of those things together. So yeah, go
Yep.
ahead.
Yeah. So just some final considerations here. A couple key takeaways I think that you want to have in mind for non-operative treatment of FAI is that physical therapy is a first-line treatment, especially in younger patients with hip pain. That really should say anybody with hip pain. I think depending on if there is some advanced osteoarthritis in certain cases or whatever, but we're still the first line for people. So physical therapy provides reliable, according to the research, reliable short and mid-term benefits with low risk. We do need more research on long-term benefit for physical therapy over other things. But it is pretty good that we can do the short-term, get some short-term improvement, and we know we're not making anything worse if we wait 3 to 6 months before trying surgery. As you had mentioned in a previous episode, corticosteroid injections, they do offer a short-term relief, but they do have risks with repeated use. So, keep that in mind. It depends on the patient. It depends how many they have. It can be helpful a little bit. Not a lot of the studies I was reading spoke on these biological injections. So whether it's hyaluronic acid or PRP, They're still under investigation about how helpful these can be and when they could be incorporated. And I think we're still learning way more about this. And I feel like for me, especially, I need an expert to talk about this topic with. I don't know enough about it to make recommendations for most things. But that's something to keep in mind. And then, yeah, more research is needed on long-term outcomes and patient selection for surgery, like who's the best fit for surgery, who's the best fit for physical therapy. But I think that 3 to 6 month guideline is important, kind of going through all the things recommended in the studies we talked about in the clinical practice guidelines and seeing if you can conquer this non-operatively or if you have to refer for surgery, that's fine too, because they do really well with surgery, which we'll talk about in a future episode.
Yeah, I would love to get like a Mike Ryman on here or a Joanne Kemp, just to ask some of these questions, because you see this research, and obviously knowing the research is important, but then when you speak to the individual who writes the research and the thought process went to this and what they actually do, right? You're like, oh, I actually, we refer out to surgery at week 8 or something like that. When, the guidelines say 12, they're like, well, for these reasons, you get some of that clinical reasoning with the research is really nice. So hopefully we get some of those folks on the pod a little bit later.
And then another final consideration is when to refer. We kind of talked about this, but it's reserved for cases that fail conservative treatment. Otherwise, you're just going to want to try it first. Typically, surgery includes arthroscopic femoroplasty, acetabular and labral repair. Better outcomes when surgery is performed within 3 to 6 months of symptom onset. That was noted here. So I think if you're pushing through conservative treatment for a year plus and you're not getting what you want, you could potentially be making things worse. We did talk about how this can progress in people. So keep that in mind, is you have some time to try non-op, but you don't want to push it forever. Large cam lesions and older age at surgery worsens the prognosis. Early surgery may be advised for younger patients with major bone changes, like the alpha angle that's super, super high over those 65 degrees, extensive range of motion loss, or early cartilage damage. Those may be folks who surgery may be better for.
All right, so you have an idea of what the literature shows about non-operative rehab for FAI. You might still have questions about FAI in general, and Kevin and I have the video for you. Over top of Kevin's head, this is where this video lives. We go over what physical therapists need to know about femoral acetabular impingement syndrome. So click on that link and we'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.